Hi, I'm Mary Stever. I am wanting to introduce and have the pleasure of introducing Dr. Joe Forrester. He's an acute care surgeon at Stanford University. He's the trauma medical director for Stanford Healthcare and the director of the Chest Wall Injury Society. He will be presenting his Ribinar for this month of March on the long haul and appropriate duration of patients with rib and sternal fractures. So without further ado, take it away.
Excellent. Thank you so much, Mary. I appreciate the opportunity to be here on the CWIS Ribinar, talking about the long-term follow-up of patients with rib and sternal fractures. So here are my financial disclosures. None of them are particularly relevant for this talk. Um, as we are all intimately familiar with, rib fractures really exist along a spectrum. They're really common injuries, and treatment for rib fractures similarly exists along a spectrum. And while I would argue that the timing and frequency of in-hospital complications are relatively well described at this point, um, we still know relatively little about the timing and frequency of out-of-hospital complications. And I think this is true not just of rib fractures, but of a lot of different injuries. And this really speaks to some of the challenges that we have in following up injured patients longitudinally in the outpatient setting. But what this sets us up for is that in absence of standardization um, for patients with rib fractures, and I think that that's led to some uncertainty within the chest wall world. There's some uncertainty within the trauma world in general about how long we should be following up patients who undergo both non-surgical and surgical management of their rib and sternal fractures. So the objectives of the Ribinar today, I wanted to use this opportunity to discuss the development of the CWIS long-term follow-up guidelines that were recently published, describe an institutional analysis that we did here at Stanford, looking at long-term complications, patients undergoing both operative and non-operative care, and then maybe wax philosophic on where we go from here. So I'll talk first about the CWIS long-term follow-up guidelines.
Yeah,
And
kind of.
these guidelines really developed out of a work product from the Publications Committee, where we convened to develop pragmatic recommendations, recommendations that we think we could actually implement in practice about the duration and follow-up for patients treated non-operatively and operatively for rib and sternal fractures. And so we set ourselves up with two clinical questions. The first clinical question was looking at adult patients undergoing non-operative management. And we asked, what is the data to support the optimal duration and frequency of follow-up to identify a potentially modifiable post-discharge sequela of injury? Our second clinical question was really structured the same way, but focusing on adult patients who underwent surgical stabilization of rib or sternal fractures. Now, to identify the references that we used in our guideline, we used a methodology for practice management guidelines that was based on a framework that's been previously published, and we conform to Wright Working Group criteria, which is really the best practice criteria for establishing guidelines. We looked at four major databases. That's PubMed, Embase, Web of Science, and Cochrane. We really tried to focus on modern studies, studies that would reflect the modern management of rib fractures. So we chose the data of 2003 or later. That was a 20-year period back in 2023 when the data collection occurred. And we shot studies where we thought that there were potentially modifiable complications with a concurrent time from discharge or injury reported. So that would allow us to identify both that a complication occurred and how long it took the complication to occur. For non-operatively treated patients, we looked at readmission, pneumonia, delayed hemothorax, surgery for non-union, or referral to pain management for post-discharge nerve block. And then for patients undergoing SSRF or SSSF, we looked at surgical site infections, implant-related infections, implant failure, or implant pain requiring removal, non-union requiring reintervention, and then again, post-surgical nerve block. So For our first clinical question, we identified 2,000 studies on initial search. We ultimately, after screening out a variety of studies for a variety of reasons, landed on 7 studies to inform a clinical question. Importantly, there really wasn't any prior scoping or systematic review identified, really underscoring the importance of this sort of research. All of the studies that we used were cohort studies, and in those 7 studies, there were 121,000 plus patients who underwent non-operative management. And in that patient population, 847 or 0.7% experienced a potentially modifiable post-discharge sequela of injury. And importantly, when we were looking at time from discharge to time to development of complication, 98% of patients experienced their complication within the first 30 days after discharge. And here's a graphical description of that same statement. Essentially, each of the studies are listed here in light blue in the graph. You can see the number of patients that were included in each study. On the x-axis is the time from discharge to development of complication. And the studies are each listed on the right, describing some of the subtleties of each of the studies. And then on the blue bar below, you can see the complication heat map. Again, most of the complications are occurring within the first 30 days after discharge. So the recommendation for the first clinical question, you can see some of the caveats to the recommendation above, but in the underlined segment, the CWIS Publications Committee recommended that patients with non-operatively managed rib fractures have planned follow-up for at least a month after their injury to evaluate for potential complications. And this was given grade 2C, recognizing the limitations in the data and the quality of the studies. So with respect to our clinical question number 2, we used the same cohort of 2,000 studies for our initial data poll. We used 21 studies for our second clinical question. Again, there were no prior scoping or systematic reviews. You can see a breakdown of the studies in the 4th bullet point. Our population from those 21 studies included 2,881 patients undergoing surgery, with about 3% experiencing a potentially modifiable post-discharge, post-surgery complication. Now, the distribution among patients experiencing post-surgical complications was a little bit wider with respect to the timing. So 83% experienced their complication within 1 year. And of these patients that experienced their complication within 1 year, 35%, so certainly a minority, or a less than plurality, experienced their complication by 1 month, although that had increased to 47% by 2 months. And again, here is the heat map showing the time to development of post-discharge, post-surgery complications. And again, while the spread with respect to time is much wider, in general, we're seeing those complications occur within the first, three-ish months after surgery, but certainly within the first year after surgery. So the recommendation from the committee was that patients undergoing SSRF or SSSF have several planned follow-up visits for at least 3 months after surgery. And this isn't to say that patients can't or shouldn't have follow-up after that, but that based on the data, a minimum of 3 months is recommended. And in the bullet point that's below the recommendation, really, if a patient has had surgery and is having persistent complications, this may be an opportunity to refer the patient to a high volume chest injury center if that is not where the initial surgery was performed, or a specialist, particularly if there's persistent or new symptoms. And this was again given a grade of 2C just based on the quality of the data that was available. So using this guideline in clinical practice, really, my co-authors and I wanted to highlight that follow-up after injury is really a complex interaction between the surgeon expectations, the patient expectations, their ability to comply with expectations, accessibility to healthcare, medical legal concerns, financial reimbursement, all of this being superimposed on the natural history of recovery. And so while it's important to come up with guidelines to standardize follow-up for patients, the guidelines have to be taken in context of an individual patient. We also wanted to recognize that there's large regional variation in reimbursement or coverage, and that our recommendations are associated with publication bias, and that represents a big challenge because realistically, long-term follow-up in non-operative patients was infrequently described. So we didn't have a great published view of what's going on a year or two after injury in non-operative patients. But again, based on available published data, we were recommending scheduled follow-up for at least a month for patients undergoing non-operative therapy and at least 3 months for patients undergoing operative therapy. So with the information from that guideline in mind, we actually took it upon ourselves here at Stanford to do an institutional analysis and look at our own complications and follow-up complications in patients undergoing both operative and non-operative therapy. So just by way of background, Stanford is a adult level 1 and pediatric level 1 academic trauma center. We serve about 2.6 million people. We see about 3,700 trauma patients annually. Most of these are blunt trauma patients. Many of them are older. We have a high frequency of falls in our patient population, and our existing guidelines prior to initiation of this study was that we followed our non-operative patients for a month after their injury, and operative patients were followed at 1, 3, and 12 months after injury. And I should specify here, the non-operative patients followed up for a month, or were offered follow-up for a month in our trauma clinic. So the study that we undertook was a 2-year retrospective cohort study looking at adult patients presenting with at least 1 rib fracture, and we chose a 2-year period, January 2020 to December 2021. And really the goal was to understand the frequency and timing of long-term outcomes and complications associated with rib fractures. We excluded patients with penetrating injury or subacute rib fractures. We evaluated both patients receiving operative and non-operative therapy, and then we captured a slew of rib-related complications, which you can see below. All of these were captured through review of their medical record. We followed each of these patients up for 2 years electronically. We are in a situation where we have both Epic and Care Everywhere. So as far as digital capture of patients, we thought it was fairly comprehensive, as many of our patients kind of stay in the greater Bay Area. We used Wilcoxon rank sum for continuous variables, anticipating non-normally distributed input variables. And then you can see we use chi-squared and Fish's exact as appropriate. We looked for association between risk factors and outcomes using a fine gray hazard model, which allowed us to use death as a competing variable. So obviously, if patients die, we want to make sure they're taken out of the analysis at an appropriate time point. And then we stratified by presence of SSRF. And so what we found were that patients undergoing non-operative therapy in our cohort were generally older and more functionally dependent at baseline, so a frailer patient population. We found patients undergoing SSRF had a higher injury severity score, more severe chest wall injuries, longer ICU and hospital lengths of stay, and higher MME at discharge. We felt that we actually did a pretty good job of getting SSRF performed early, a median of 2 days after admission. About 10% of our SSF patients developed pneumonia, while 4 not receiving surgery developed pneumonia. And our mean duration of longest follow-up, which was censored at 2 years, was 39 weeks. Was 80 weeks with a standard deviation of 39 weeks. And 36% of patients in both groups were lost to follow-up. So to briefly describe some of the complications, we had 904 patients receiving non-operative therapy, 72 receiving surgery. Of the patients receiving non-operative therapy, rib-related complications were actually only identified in 13 patients, 10 of whom required readmission. And the timing of the post-discharge complication was about 1.6 weeks, so just under 2 weeks, which would be consistent with the CWIS guideline data that we reviewed. In patients undergoing SSRF, the complication rate was very low. But similarly, the these complications were initially identified relatively early after discharge at 1.4 weeks. So to the bullet point below, more than half of the patients in each group experienced their complications within the first 2 weeks after discharge. I'll go through some of the data here in just a couple of slides. Here you can see the adjusted risk of related complications among non-surgical patients, and really the greatest driver of risk for complications was the presence of a pneumo or hemothorax on arrival. Not captured in this data set is just anecdotally amongst our trauma patients, we have watched our delayed hemothorax rate drop to nearly 0% after starting our SSRF program. So I think that has had a pretty profound impact on those particularly older patients with delayed hemothoraces. Here is a B-swarm plot, essentially showing the same data. There'll be 4 of these B-swarm plots that I show. This is just a graphical way to show how far from discharge each of these complications are occurring. And you can see here, this is a B-swarm of the rib-related complications, and you can see that most of these complications are occurring within 2 weeks. Similarly, here's the B-swarm plot showing the time to the development of pneumonia. You'll notice that the y-axis has changed here. On the y-axis is now days as opposed to weeks. So again, most of these patients are showing up with pneumonia within the first 2 weeks after their discharge. Here is our diagnosis of new alcohol or opioid use disorder. Interestingly, this was a little bit more broadly distributed over a span of many weeks after discharge. So I think underscoring the importance of longitudinal follow-up for injured patients and a potentially under-recognized long-term complication of trauma. And then finally, here's our B-swarm plot looking at all-cause mortality. Again, you can see a broader distribution here, particularly among the non-surgical patients. So just to provide a little bit of a deeper dive on the mortality, our all-cause post-discharge mortality over 2 years was 8% in the non-surgical group, 3% in the surgical group. None of the mortalities are actually associated with the surgical intervention, but it just goes to underscore that even when you select patients well, when you're operating on older frail patients, there's a pretty high mortality rate just associated with having rib fractures in general. The median time to death was 31 weeks in the non-surgical group. And in the non-surgical group, mortality not unexpectedly was associated with increasing age. So in conclusion, from our institutional study, the overall rate of complications was quite low in both the non-surgical and surgical groups. Most surgical complications were identified within 2 weeks of discharge. And it helped underscore that early follow-up is prudent, but left a little bit of doubt in my mind about the benefit of longer-term follow-up, despite that being the practice that I perform with the patients that I operate on. So where does this leave us? I would argue that we are still very much in an area where there's a lot more information that we as a community of providers who care for injured patients, and particularly injured patients with rib fractures, need to get more data on. I think there's a lot of data to suggest that early follow-up is important. I think there's not as much data to support how long we need to follow patients. I think that there's a benefit to the provider to following patients long-term because you get to see your outcomes over time, and you get to develop that relationship with patients that is professionally very rewarding. But it also comes at a cost to the patient and a cost to the provider. So if there's really not a net medical return on investment, maybe we should be truncating follow-up. It's also possible that if someone's going to develop a long-term complication, really what we need to be doing is focusing on identifying that earlier, as opposed to waiting to a year to 2 years to identify a post-discharge complication, particularly in a patient who underwent surgery. So those are just some of my musings on follow-up and the data that is that we currently have supporting the CWIS guidelines. So with that, I would be happy to take any and all questions. I can't promise I can answer them, but happy to try and attempt to do so.
Well, hey, thank you, Dr. Forster, for that. First of all, your Venn diagram speaks to me. I think I find myself in those who are very confused at the moment in my life. So I appreciate that. So I know it's not unusual and this is not specific to my experience as a trauma surgeon, but as far as follow-up, how did you ensure? Obviously, we know that a lot of our trauma population are not really great about following up. What are some tips and tricks that you have for the people on the net about ensuring those follow-ups, or what kind of communication do you have with your patients to get them to follow up so you can do those short follow-up visits?
Great question. So within our health system, the injured patients essentially have a 3-week window, 3 to 4 week window where they can come back essentially free of charge for their initial trauma follow-up. Um, so decreasing the financial barrier helps. Um, what we have also done within our acute care surgery group, so this is for both trauma patients and our emergency general surgery patients, is that once a patient is discharged, they receive phone call follow-up within about 48 hours after they're discharged to make sure that they're aware of their opportunity for discharge or understand their patient instructions. And that we found has also helped. Um, Broadly across our Department of Surgery, we have undergone pretty significant changes to our discharge instructions, and we've made sure that our discharge instructions are translated into our high yield languages, so not just English, but Spanish, Russian, um, uh, Mandarin. It's having discharge instructions that are in a language that the patient can understand is very important. And so while not unique to our trauma program, it is something that our Department of Surgery has been very intentional about.
That's great. I have a question here from Ali Abbasi. Are all follow-ups face-to-face, or do you do remote video call follow-up?
Great question. We try to do follow-ups in person when possible, but we also do remote follow-ups as well.
Joe, can I ask a question?
Yes, please.
Um, I'm interested in the group of the patients who got non-operative therapy, but who went on to develop a pleural space complication. I think you've shown nicely, and we did in a very early study a decade ago, that if you operate on these patients, you virtually eliminate their retained or delayed hemothorax issues. But it looks like that doesn't necessarily translate to those patients we don't operate on. So, do you have any insight into if those patients require the ones that develop the pleural space infections? Have you had a chance to go back and sort of microanalyze those? Were they discharged with insignificant quote unquote hemothoraces? Did any of them get chest tubes before they left? Does that lower their risk? Those kinds of questions, because that seems like to be an area of where we might make some impact on those patients we don't operate on.
Yeah, great question. For this study, we didn't go back and look specifically at those patients. I will say anecdotally, in my role as the TMD and reviewing the cases, what we see is that it's frequently patients who, didn't have a hemo or pneumothorax um, while hospitalized. Their fractures, didn't look bad on the initial CT scan. Their pain was adequately controlled, but they were on some sort of blood thinner and were elderly. And so when they get to a rehab facility or get home and start becoming more active, I think you know, presence of blood thinner plus increased activity has led to the potential for a delayed hemothorax. But again, that's anecdotal. That's anecdotal just in reviewing a bunch of cases, not with the actual hard data.
So that's a high risk group then for hemothorax. And so, do you manage them differently? Do you think we should manage them differently?
Um,
Follow them more closely, X-ray them sooner? What's the solution?
yeah, great question. So, and I guess I have a couple answers. In general, I think we're pretty aggressive about being willing to operate on frail patients, recognizing that when they have complications, it can be very hard to rescue them. And so I think we have very much embraced the too frail to fail mentality. So we increasingly offer those patients an operation. We get a 2-view X-ray on discharge and a 2-view X-ray when they come back to clinic as part of our trauma process to help try and identify a hemothorax early. I will say just for myself, if a patient comes in with rib fractures that are anatomically suitable, but maybe on the cusp of like, oh, okay, like maybe not as displaced as I would normally plate, but they're on Plavix, so they're on a DOAC for a heart indication, then I'm much more likely to offer that patient surgery.
Thank you.
That was going to relate to my question, Joe. And let me just adjust my camera here. There, that's better. Has your view on imaging changed? I know you were a late follow-up. You do imaging far down the road, especially for your operative patients. But it sounds like, at the end of your talk there, you have kind of moved. You're questioning the cost effectiveness of that. So have you changed your practice, or are you thinking about it?
Yeah, great question. I have not changed my practice, but I do think about it. And it's I mean some of that has to do with the fact that like once you start a train moving down the tracks, it can be hard to stop the train, and you have a system that's built in place. But the reality is like I probably don't need to be getting chest X-rays a year out for a patient who's otherwise asymptomatic and feeling really good. And the reality is we may not need to follow patients for a year out at all. And maybe we stop following them at 3 months, get a chest X-ray at 3 months, and if they're feeling fine, then they don't need to come back. But I have not yet changed my practice.
Is there a role in studying that? We have a very wide practice variability among the collaborative centers, I'm sure, for example. So
Yeah, absolutely. I mean, I think in general, follow-up is among injured patients is something that we don't know a lot about, and particularly as there's increased emphasis on the importance of patient-relevant outcomes. There's a lot of opportunity there for scientists who want to learn more about how people recover from injury, both for rib fractures and other injuries. I do like your shirt though.
you break them, we fix them.
A follow-up question: in the ones who developed hemothorax, had the fracture been displaced? Was it a displaced fracture in those patients? That's a follow-up question.
Um, yes, I say that with a little bit of hesitancy because it varied. In general, when patients have 3 or more displaced rib fractures, we're pretty consistently offering them an operation. But I'm sure there were some in there who had displaced fractures that we didn't operate on.
One additional question I had is, in the trauma bay, do you use any, like if you place a chest tube, or what do you use for antibiotic prophylaxis, or do you have a protocol there for antibiotics?
As part of our guideline, we currently are using Capsol single dose time of chest tube placement. I know several of the national and international organizations have gone back and forth on that, but that's what our current trauma guideline is.
Yeah, that was consistent across where I worked as well as when I did my fellowship. So just curious.
Same here, if we remember.
Yeah, it's always a little hard if someone comes in and it's in extremis to make sure that it happens, but yeah, we try to.
Well, are there any other questions from the chat or the group? All right. Well, Sarah, I'll turn it back over to you for follow-up comments. It looked like she might have fallen off.
Oops.
Oh, there you are.
There we
Okay.
go. Okay. Thank you so much, Dr. Struber, for
facilitating our discussion today, and Dr. Forrester for presenting and certainly leading out on this publication. Super exciting to have this moving forward. I think we mentioned the full publication is available. Remind me, was it last month? Last month's JTAX?
Sounds right.
January? I can't remember exactly when it was published.
I think it was in the CWIS edition, but I could be wrong on that.
Was that okay? It's all blending together now. This close to the summit, everything feels like a blur of days. So I don't remember exactly, but I will, when I send out the recording for this event, I'll make sure that I include the citation as well, so that you can you can pull the actual publication if you're interested. But of course, the recording will be available that you can rewatch if you have any additional questions or want to share with colleagues. Thank you so much again for leading this project. I know also to Dr. Kartiko and Dr. Patel, who were very hands-on in the process. As far as next steps, next Wednesday at this same time, we have Journal Club. So watch for a notification about that, which will be coming out soon. The gentleman who will be leading it is, I believe, a pain control specialist. I can't remember. Recently released a publication regarding PERT cryo and some interesting information that I think you'll really want to be a part of, just regarding analgesia options. So please go ahead and get registered and watch for that notification. If you have any questions, let me know. Oh, and the next Wednesday, so 2 Wednesdays in a row, the next Wednesday is CWIS case review, and that will be at 1 p.m. Mountain Time. So you've got three Wednesdays in a row, good educational content. And then we're taking a little bit of a break to gear up for the summit at the end of April in Atlanta. So if you have any thoughts, questions, needs to get ready for the summit, certainly let me know. Reach out to Dr. Forrester as our education chair, Dr. White as our program chair, or we have multiple members of the education committee here on this call, including Dr. Falix, Dr. Struver, etc. So please feel free to ping any of them with any questions and let us know if there's anything we can do to help. Thank you so much. Have a great day.
Thanks, Joe.
Bye, guys.